Okay. Sorry, we're having some technical issues. Okay. Can everybody hear me? Uh-oh, no audio. Uh-oh. Did you hear anything I said earlier? Okay. I was just welcome you guys. This is me. I'm going to share my PowerPoint presentation in a second. And I welcome all your questions through the chat. And then we can also do video chat if you prefer that later. But I'm going to try to get through my presentation and then we'll bring up some questions because I'm sure there's plenty. So let me go back to my presentation. All right. Okay. Can you see my presentation? Someone say something. Okay. So I named this one Dealing with Menopause, and I was just telling Heather that slideshow. Sorry. Where's my slideshow? I think it's hiding. Sorry, guys. Oh, here we go. Slideshow. Okay. There we go. Sorry about that. So I was just telling her that I named this appropriately, I think. Although I have not hit menopause yet, it's coming. And I think that Dealing with Menopause is the absolute appropriate title. And I'm sure some of you will agree. So we'll just get started and just talk a little bit about some of the things that can happen. So first things first, the most common time that it happens is between age 45 and 55. 50 being the average, and most 50-year-olds are heading into menopause, if not already in menopause. The lack of estrogen and progesterone is the reason for most of the symptoms. So some things like increased cholesterol, osteoporosis or decreased bone density, and then decreased activity of the GI system leading to constipation are probably number 1, 2, and 3 of issues, along with dry and atrophic vagina, pain with intercourse, and then leading to increase of urinary tract infections. Also, weight deposition changes. Definitely people will say that they feel like they gained weight, but I think it's more that it's distributed differently. That is a real thing with decreased estrogen and progesterone. Also, as time goes on, as we age, as we lose our estrogen, we also lose collagen and elastin. And of course, our skin becomes a little thinner, finer, and looser. So it's kind of becomes a little bit saggy, but I'm going to blame part of that on gravity. A lot of people will start complaining about irritability. Some people will have depression, mostly just anxious feeling and changes in their general mood is most people's complaints. Hot flashes, of course, is notorious in menopause. I'll tell you that there are some people that do not get hot flashes. I usually tell those people not to tell other people because otherwise we'll all be super jealous of not having hot flashes. But there are some people that don't have hot flashes. The easiest way to know what kind of menopause you're going to have is to talk with your own mom. Your mother's menopausal syndrome is usually what you will mimic. Along with hot flashes are night sweats, and then low bone density, like we talked about, and then vaginal dryness. Along with vaginal dryness, of course, is painful intercourse, and like I said earlier, frequent UTIs. The hot flashes can occur any time of day. A lot of people will complain of it at night, and a fan or even some sleep aid medicine is actually the treatment for that. There's also, of course, hormonal and non-hormonal treatments, but it just depends on the patient. With the mood changes, like I said earlier, irritability, depression, insomnia can be related to hormone imbalance. And then, of course, when you start having hot flashes, you're losing sleep, and then that also triggers fatigue, irritability, depression, headache. Along with that, there is definitely a decrease in libido. Some people will say that they have some increased libido, which is amazing, but decreased libido is common and can be related to actual hormone issues or vaginal dryness. The weight gain, belly fat, distribution of weight is likely hormone related, but also, you know, when your mood is off, then everything is off. You're not exercising, you don't feel like it, you just feel crappy, and then you don't sleep and you don't exercise and you eat badly, and it's a vicious cycle. So I'm not saying that it's not hormonal. I'm just saying that the hormones don't always cure everything. So I wish that I could just cure everything with hormones, but sometimes it's a combination of all the things that we talked about. Any exercise is great. The best exercise is the one that you love doing. So treatments, let me skip to this one real quick. So when to seek treatment, I think, is the first question. I have many patients that will come in and ask me if they should get on hormone replacement therapy, or if they should get on meds for menopause, or if they're heading into menopause, what they should do. And I think that this is all good questions, and it really is different with every patient. You know, if you're having symptoms, talk to your doctor. If you're having anything that's odd, talk to your doctor. Is it hormonal? Well, good question. Checking your hormones is kind of controversial. I know that you can check hormones and you can treat accordingly and it helps, sure. But I also think that there's many people that have normal hormones who have symptoms who still warrant treatment. Not all treatment is hormonal. So depending on where you are in the menopause syndrome, we will consider non-hormonal treatment. And then if it's officially menopause, then we'll consider hormone replacement therapy along with non-hormonal, depending on, again, the symptoms. So like I said, it's individualized. It's really just diagnosed through, sometimes with a lab test, but really just no menses for 1 year classifies as menopause. Those that have had surgical menopause is kind of a different story. So I might not talk about that a whole lot today. I just can say that surgical menopause, meaning if you take out your ovaries, which is not as common as it was, under the age of 60, really, or even definitely under 50, is surgical menopause, and is usually much more severe and definitely warrants a hard look at hormone replacement therapy. So non-hormonal treatments include decreasing caffeine, decreasing alcohol, and sometimes some sleep aids, like we talked about. Ambien is a really common, easy one. Melatonin, of course. In fact, even CBD is a great sleep aid. It just depends on the dose and the patient. Also things like Paxil, Prozac, Seraphim is actually indicated, as well as Paxil 7.5 milligrams is indicated for non-hormonal treatment of hot flashes. Regular exercise, balanced diet, good sleep. Again, I can't seem to emphasize that enough. I think is really crucial, and whatever can improve your sleep is going to improve your hormones, your mood, your symptoms, and in general, overall well-being. Calcium and vitamin E for bone health, mostly vitamin D, and definitely worth talking about with your provider, and possibly getting some lab tests, but also checking for bone density at some point in your menopause journey, we'll call it for now. Vaginal dryness is really tricky. Water-based lubricants are not great because it's kind of like, you know, water versus saliva. So depending on how severe it is or what the real issue is, it's worth planning for lubricant or hormonal treatment of vaginal dryness with a vaginal estrogen. So hormonal treatments include oral estrogen, progesterone, and or testosterone. Same with transdermal. They can be in a cream form, that's really common, and also patches. And then, of course, pellets. I don't do pellets, but many OB-GYNs do, and I think it's worth looking into. Most insurances don't cover it, but I start with oral or transdermal because I think it's easy and it's covered by insurance and it's safe. And then if you're still having issues, then pellets are 100% reasonable, and or referral to the gynecologist. Indications of hormone replacement therapy is really symptoms, you know, relief of symptoms, hot flashes. Pretty much the only thing that treats hot flashes is hormones. I think it is definitely indicated unless there's some contraindication. So smoking is a contraindication, and family history of blood clots is a contraindication. And of course, surgical menopause is a definite indication, not contraindication, indication. But otherwise, it's really a safe treatment, and anything that helps you have a better quality of life is good for you in general and for your general well-being. This is just a little bit more about the types of hormone replacement therapy. So estrogen, progesterone combination, estrogen only, progesterone only, and then of course there's also testosterone, which I don't talk a whole lot about because that's dependent on the person really and symptoms. So testosterone is pretty good for energy and for libido, and just in general balancing the other hormones out. These are the common ones. So you guys might have seen some of these. So daily estradiol is a pill, progesterone is a pill. The combination was Premarin. It's pretty expensive now, so I don't think a lot of people are using that since we have generics. And then of course the estrogen onlys, which are reserved for those without a uterus, oral or transdermal. Again, pellets, usually those are usually combination estrogen, progesterone, testosterone. Vaginal estrogen, which is specifically for vaginal dryness. And if you have vaginal dryness and other things, you can just take oral hormones and that will solve that problem as well. Usually the duration of your treatment is about 5 years. We usually reassess after 5 years and definitely after 65, basically because even though you are menopausal or postmenopausal and your hormones are low, it doesn't mean that you have none. And so it dwindles, but after 65, there's very few patients that will complain of symptoms. There are some, but very few. There are some risks related to HRT. It's minimal. I've written them down here just because a lot of people will ask me about that because there was some controversial issues about this, like, oh, I don't know, more than 10 years ago now. To me, it's a pretty much non-issue. I think that quality of life trumps any of these things. These are not statistically significant cases and worth a discussion with your provider. Again, the risk of estrogen alone in those without a uterus are far and few between, but those with a uterus is contraindicated to take just estrogen. So the combination is okay, but of course, not alone. So the risks in general are higher as you get older. That's why we reassess every 5 years and at the age of 65. So the lower absolute risk is in younger menopausal women, postmenopausal women, and again, worth a discussion about hormonal and or non-hormonal treatment for symptoms. So overall, HRT is a safe option for healthy symptomatic women who are within their menopausal years and definitely younger than 60 without contraindications. So again, like I said, a history of breast cancer, heart disease, stroke, and smoking. And then it is effective for hot flashes especially and vaginal atrophy especially, but it's also helpful in many other scenarios. So worth discussion. These are just a few extra little words about cardiovascular disease and reasons for why as women we are much less at risk for cardiovascular disease, and it's because of our estrogen. So as we get older, our risk of cardiovascular disease goes up because of the decrease in estrogen. And I think I'll just start with questions. Let's see, anything in the chat? So static. Okay. So if anybody has any questions, feel free to jump on or send me a message in the chat or send us a message in the chat with a question and I'd be happy to start answering them. I'm surprised. Last time we had a lot of questions. Everybody just on lunch and eating. I might have gone through that kind of fast. So if you do have a question, please. Let's see. Why is testosterone not prescribed more? Oh, okay, that's a great question. So because many people don't like the side effects if you get too much testosterone. So it's hard to gauge how much testosterone a woman needs. if you get too much of it, you definitely get acne, you can get some hair loss. And as much as we want to increase our libido, we want to be not quite where men are, probably. So I think that's probably one of the reasons. And the other thing is, it's so subjective that it's hard for doctors to say, you know, that you need testosterone if you don't have a complaint, I guess. The next question was about taking estrogen and progesterone and if testosterone would help. So it just depends on your symptoms, you know, and what the issues are. It could help if you're having libido problems or energy issues. Sometimes with the weight distribution, it can help with that too. I have had lots of complaints about estrogen, about testosterone, but I've also had plenty of people that love it. So one of my patients actually told me that she got off of it because she felt like she just was eating more. But one of my patients was like, I had to decrease the amount of testosterone I was taking because I jumped my husband in the middle of the night. So, you know, there's somewhere in between for everyone. I have a private message about whether menopause could help people who have PCOS. Yes, I think so. That's a very good question. I think that the hormones in general play a part in that. So it can help, but it's not guaranteed. I think I definitely have less patients complaining of PCOS related issues when they're postmenopausal. And a test does not have to be done to confirm menopause. That was the next question. Should a test be done to confirm if you're in menopause? It does not need to be done. 1 year no menses equals postmenopause. Unless you're super young, like, you know, in your 30s or even in your early 40s, it's worth checking a lab but if you're around 50 and you've had no period for 1 year, we can assume it's menopause. Someone's asking about how they had a hysterectomy at 33, got on estrogen at 36, and now is 43. So if you had a hysterectomy and you had your ovaries removed also, then you were already in menopause, so meaning postmenopausal. But if you did not have your ovaries removed, it really depends. So I would talk to your gynecologist about that. Let's see. Are some of the non-hormonal products available over the counter? It's another question I just got. Yes. So vitamin E, black cohosh, those are supplements that are over the counter. I guess CBD is over the counter as far as non-hormonal meds, melatonin, of course. But it just depends on how severe your symptoms are, I think, and how you're doing on over-the-counter meds versus getting prescription meds, whether they're hormonal or non-hormonal. Here's a question about natural HRT. So what do I think about natural HRT? I'm not sure that I know what that means. So if you're talking about bioidentical hormones, I'm fine with bioidentical hormones. I think that if that works for you, that's great. They're still hormones, so don't feel like you're getting something that's not still estrogen, progesterone, testosterone. Sure, it's not synthetic, but it is still hormone. So it just depends on where you're getting it, and hopefully prescribed by a practicing provider. Here's another question about, since the hormones play such a role in how people feel and do affect the quality of life, why doesn't insurance cover the pellets? Oh, I wish I could answer that question. I wish that insurance would pay for all the things that doctors think are helpful, but it doesn't. And I think the short answer is that if there is something technically available that is cheaper, then they always go for the cheaper option, unfortunately. Is there something that helps with weight gain if diet and exercise is not working? So yeah, there's lots of things that can help. Again, I think that testosterone and hormones can help, but also just like a long, hard look at your general well-being and sleep, I think is usually part of the problem. So I would be interested to hear more about how you're doing with your sleep and what your diet is and what your exercise is. I would encourage weight-bearing exercise versus cardio, maybe. that might help because you're not just trying to like lose weight, you're trying to actually redistribute the weight most of the time. So that would be something that you could definitely address with your provider. Here's another question. Will the body balance itself out without HRT? So you could like wait it out. Oh yeah, I mean, your body will, but I guess my big take home on that is there's no point in suffering, and there's no point in people around you telling you that you're driving them crazy. I understand waiting it out, but I do not understand suffering it out. I heard recently from someone not related to menopause, but I think appropriate and a good place to put this is that there is no award. There's no reward for suffering. And I think as women, especially, we suffer it out. You know, we call it waiting it out, but we suffer it out. So I think that it's important for everyone to take that to heart a little bit and know that if you're waiting it out and you're like, I think I'm fine, that's great. But if you're not fine, don't keep suffering, because everyone around you is suffering too. And you're not helping others if you're not helping yourself. Is there an option for someone with breast cancer history? Yes. So depending on what your treatment for breast cancer was, there are many options. Most are probably non-hormonal if you did not have, well, even if you had a mastectomy, probably non-hormonal treatment is worth doing. But I have a couple of patients actually on vaginal estrogen specifically, and they both had breast cancer, and that is not contraindicated. We've looked it up and talked to many oncologists, and that is safe. Let's see, we'll give everybody a second to take a sip of water. Any questions from my live audience? Can you get more info on non-hormonal treatments? Sure. I mean, I think that it's probably worth discussing with your doctor, but it depends on your symptoms, you know. I mean, this is not meant to be me as your doctor, but I think it's worth looking into depending on what your symptoms are. So mood or sleep, weight gain, weight distribution, libido, all those things can be addressed with non-hormonal treatment. Does HRT have side effects that will outweigh the benefits? Side effects, not so much. Potential complications, yes, of course. So it will not outweigh the benefits, I don't think. I mean, that's the whole point. You know, we don't try to give you something that will have more risk than benefit. There's always a risk to every single treatment. So the potential risks of hormones are increased risk of blood clot. That's really the biggest risk. And let me think of what other possible side effects. Well, the risk of increased estrogen is breast tenderness, usually temporary. The increased risks, side effects of testosterone, like I said, is hair loss and acne. I'm trying to think of what other side effects. Honestly, I think that the benefit of HRT outweighs the risks in patients that have significant symptoms. And I think that all my patients would agree. Are there some patients that still don't do well on HRT? Yes. Do they still have hot flashes? Yes. You know, but the vast majority of my patients that have had hot flashes are now on HRT are having at least 99% less hot flashes. So doesn't mean you'll never have a hot flash again. I wish, but definitely a lot less. I have a question about how long one should be on HRT. So at least a few years, but it depends on the patient. 5 years, we reassess, and then definitely over age 65, we really consider stopping because of the risk of blood clot. That's really the biggest risk. On the hair loss, do you recommend anything extra like Rogaine or something? Hair loss from menopause or hair loss from testosterone? I guess that's my question. Hair loss from menopause is not usually secondary to hormone imbalance. Definitely Rogaine helps. There's women's Rogaine, and actually in severe cases, I recommend pouring Latisse. You guys probably know what Latisse is. It's the eyelash stuff, into a bottle of Rogaine and then spraying it on your head. Apparently that works really well. And if it's too much testosterone, then we can address that in a different way, depending on if it's external testosterone or internal testosterone. Hopefully all of you have a primary care doctor that you can talk to about these things. I think that gynecologists are very willing to talk about these things also, just that they're usually really busy with pregnant people and you know, sometimes you have to wait like 2 or 3 hours. So most primary care doctors, I would say, can definitely address your menopausal issues, and I just say issues in general because there's plenty, and that's kind of why I call it postmenopausal syndrome, because it's just part of life and we learn to manage it, or we manage it together, and what works today may not work in a month from now, or may not work from 6 months from now, because your body's changing. So I have another message that says something about how 5 years of hormone replacement therapy is a long time, or seems like a long time. And again, this is all like depending on the patient. There is no reason that you have to be on hormone replacement therapy or meds for 5 years. Of course not. The question is, do you want to stop it every month, have a hot flash, and then restart and recalibrate every month? That sounds like more painful. Your body can balance itself out, but everybody's different. Some people have 0 hot flashes. So I don't know how many of you guys are postmenopausal versus perimenopausal, or just interested in hearing about menopause, but everybody is different. I have plenty of patients, more than I ever thought, that literally said, oh yeah, I went through menopause, it was fun. I'm like, sounds great, you know, but I have a lot of patients, just as many, maybe more, that say that they have, you know, incapacitating hot flashes or horrible mood swings where they hate their husband, or you know, they're like so irritable with their kids that they just that they want to beat themselves up about it later, you know. So that's not helpful either, I guess, is my point. So if you're having issues and you think it's your hormones, it's worth treating so that you can take care of yourself and your family and whoever else is around you. And that the benefit, I think, outweighs the risk. Let's see, that's, anybody else have any questions? I hope that was helpful, and I hope that maybe you have more questions for your doctor, and hopefully your doctor will be open to having this conversation with you and discussing non-hormonal and hormonal treatment, right? And what's right for you. So everything is dependent on you and the part of menopause that you're in, and again, like specifically your symptoms. Oh, I have a person that wrote in that she has hot flashes but no mood swings. That's good. That's great. I mean, except not really, you know. So could your mood swings start later? Yeah, sure. They may not, though. You know, this is the problem with menopause, I think. I wish it was like high cholesterol. You have high cholesterol, we need to do this. You get to have Crestor or Lipitor or something along those lines, and that will fix the problem. That would be so easy. I wish that menopause was like that. That, you know, you have menopause, we give you estrogen, progesterone, and you're better. Unfortunately, it's not so simple. And as we all know, we are women, and we are not simple. So somebody's asking about in labs to determine the level and getting on HRT to target the symptoms. So like I talked about that a little bit in my presentation, but basically I don't check labs. I think that you can, and maybe it'll be helpful for some people. I didn't learn that way. I learned that I'm not treating the number, I'm treating the person. So as long as you're post-menopausal and not, perimenopausal, that's the main thing. You don't want to get on hormones too early, I guess. So if you're post-menopausal and we get you on hormone replacement therapy, we're just essentially titrating it based on your symptoms. I'm not going to increase your estrogen because your lab test said that you're on too much or whatever. I mean, that doesn't make sense. If we're still having hot flashes, then we go up on the estrogen and we go to the dose that is reasonable for you to deal with and that's safe. And then, so I don't really see the value in checking labs. I mean, I think that when you're perimenopausal, there can be some value, but I had a patient that I checked labs on a few months ago, and she's perimenopausal basically. So that's the reason. And we found out that her testosterone is, low. Well, I mean, her testosterone is supposed to be low. All her other labs are normal. As a 45-year-old woman, why would you not have low testosterone? But the question is, what is your issue? Is it because you have low libido? Is there some other reason you have low libido? Because testosterone is not the number one reason for low libido. I'm not sure if you guys are following me, but anxiety, depression, stress, not sleeping, those are really bigger reasons. Trouble in your relationship, something on your mind, those are big reasons to have low libido. And I heard one of my preceptors once upon a time said, I think I said this in my last presentation, that libido changes as we get older. So at one time, I think as women, we may have been microwaves and we get heated up when you turn us on, but now we're crockpots. So it just takes a little while longer. So I guess, that's just something to think about. It's not just that you can't get to where you need to be as far as your libido goes. It's more like, it's just different. It's not the same body as it was 20 years ago. Just like when you were 35, your body was not what it was when you were 25. I have a couple of other messages here. I currently see an endocrinologist for thyroid disease. Do you take patients for other than hormone treatments? Yes, I treat general everything. So if you need a primary care doctor, we'd be happy to see you. Maybe you can send Heather a message. What was your email again?
At healthtexas.org.
QP, let's write that in the chat. You read it in the chat? Okay, she'll write in the email address in the chat, and maybe if you want, somebody at Health Texas can help. Let's see, another message. I had to go through menopause when I was 44, recovering from breast cancer, being on tamoxifen for 8 years, and then start over with natural menopause. Yes. So my treatment for the side effects changed. So yeah, exactly. So it changes. Everything changes depending on what's going on. So there's a message about green matcha tea. That's great. If your hot flashes are reduced, that's what you do. I don't know if that's better or worse than estrogen or non-hormonal Paxil or paroxetine at 7.5 milligrams. But if it works for you, then great. I'm not sure that I can guarantee that'll work for everybody though. So I guess that's the bottom line. I think we'll probably wrap it up. If you guys are ready, I'm open to any more questions. You can send them to Heather at qpic@healthtexas.org. That is in the chat. And hopefully that was helpful, and you're not alone, I guess, is the big message here. And hopefully you guys learned something. So thank you very much for your time, and we'll see you again next time.